We have seen the two different types of wounds in palliative care. One is pressure ulcer and the another one is fungating wound or a cancer wound. So let me discuss with you first on pressure ulcer. We all know that what is pressure ulcer. Okay. So pressure ulcer is a localized injury to the skin and the underlying tissue, usually over the bony prominence, as a result of prolonged unrelieved pressure. So if there is a prolonged unrelieved pressure there is a chance of pressure there is a chance of damage of skin under the bony prominence, especially under the bony prominence, but it can occur anywhere. Okay. So this is called pressure ulcer. So let's see what is the pathophysiology of pressure ulcer. You can see a patient lying on a bed. Just imagine a patient lying on a bed in supine position. So when a patient is lying on a bed, what happens? Usually, because of their body weight, the underlying tissues are compressed. Okay, so you can see that picture, pressure for a long time, that leads to collapse of blood vessels. If the blood vessels is not functioning well, what happens? The tissues may not get adequate nutrition, and finally tissue ischemia and stress breakdown. This is the pathophysiology of pressure ulcer. So why I am telling this pathophysiology with you all is, you all know that, but if we see a bed-bound patients in your practice, you have to keep it in mind and you have to encourage the patient and educate the patient about the importance of prevention of pressure ulcer. So they should know what is the pathophysiology of pressure ulcer. Then only, if they know well, they will try to change the position 2 to 3 hours. Okay. So coming to the risk factors, the first one is friction. So there are 3 major causes of pressure ulcer. One is continuous pressure. The second one is moisture. The third one is friction. So these are the major causes of pressure ulcer. So here also the risk factor is, the first risk factor is friction. How does it happen? So for a bed-bound patients, just imagine. So they need to change the bed sheets. Okay. So within the hospital, we are there. Our nurses will take care of the patients. Our nurses knows well how to change the bed sheets for a bed-bound patients. But when they go back to their home, who will take care of the patient? The caregiver is the person to take care of the person. So the caregiver that doesn't know how to change the bed sheet, they usually what do is they will pull the sheets under the patients. So there is a chance of friction. Okay, so there is a chance of injury. So and the second thing is shear. So here you can imagine an obese patient. So they usually lying down, but for an unconscious patients, they usually slipping downwards. When we try to re-back to their normal position, we usually apply more pressure on force to their body. So there is a chance of deep tissue injury. So there is a shear force. And impaired sensory perception and impaired physical mobility. Here, what happened is you can see you have seen a lot of paraplegic patients here. So they may not sense the lower part of the body. So paraplegic patients are the risk group for getting pressure ulcer. The next thing is altered level of consciousness, either semi-consciousness or that unconscious patient, the patients will get pressure ulcer because they are not able to move independently. Continuous pressure because of the unrelieved pressure can cause pressure ulcer. And fecal and urinary incontinence. Again, the paraplegic patients, if the patient is getting spinal cord injury, they may not get the sphincter control is the sphincter control will lose and that patient will have a fecal and urinary incontinence. So as I already mentioned, moisture is one of the major cause of pressure ulcer. Here, if there is a fecal and urinary incontinence there, continuous moisture will be there. Again, this is one of the major risk factor. and malnutrition, dehydration. So we all do that pressure, change the position and give air mattress or water mattress, whatever it is, everything we do, but we don't usually we don't give much attention on the nutrition part. So lack of nutrition is one of the major risk factor, and excessive body heat and advanced teeth. These are the risk factors of pressure ulcer. So coming to the sites of pressure ulcer, you can see that images, even if the patient is supine position, side-lying position, the Fowler's position, even wheelchair patient is also getting pressure ulcer. It can occur anywhere in the body. You can see these images, heel, occiput, scapula, toes, sacrum. These are the areas. This picture, from this picture, we have to understand that it can occur anywhere. Depends upon the patient's body position, it can occur, but mainly it's on the bony prominence. So coming to the position in supine position. So occiput, elbow, sacral region, heels, and scapula. So these are the common sites which the patients can develop pressure ulcer in the supine position. Why I am telling these pressure point areas is, so we need to change the position from supine position to left lateral or right lateral position after 2 hours. So when we change the patient from supine position to side-lying position, we need to give a special attention for those areas, because if there is any color change there, we need to find out initially, and we have to give a proper attention to that areas. Coming to the side-lying position, you can see in side-lying position also, ears, shoulder, elbow, hip, heel, these are the major, the common sites, major points. Here, you have to give a special attention in between the knee, because the in between the knees are rubbing together and can cause friction, and then the patients can develop pressure ulcer between the knees also. When the patient is lying down in the side lateral position, either right lateral or left lateral position, better to keep a small pillow in between the knees, or you can keep a folded sheet in between the knees. Otherwise, it can cause pressure ulcer. And the Fowler's position. Here, this is one of the best position for dyspneic patients, breathing difficulty patients, but even if the patient is in Fowler's position also, we have to give at least a 10-degree position turn is mandatory. So 10 degrees, no need to put the patient in supine position or a right lateral or left lateral position, but you have to turn at least 10 degree, either right side or left side, so that continuous pressure will reduce. Coming to the prone position. So here, if the patient is having a huge pressure ulcer on the sacral area, we used to keep the patient in prone position. And also, if the patient is undergone maybe they are planning to undergo the surgery like flap surgery, skin grafting procedure. So after the skin grafting procedure, they have to lie down this the position only, prone position. So before they going to the procedure, surgery, we need to train the patient in prone position. We have to train them, and we have to make sure that whether the patient is able to continue the prone position. So otherwise, the surgery is not benefit. And then coming to the stages of wound. So the first stage is a non-blanchable erythema. You can see this picture. So non-blanchable erythema. So if in this stage, if you give a finger pressure on this area, that the red color is there. There is not blanching there. So that is called non-blanchable erythema. This is the stage 1 pressure ulcer. Coming to the stage 2, if you are not getting in the first stage, the not give much attention on that first stage, definitely the skin will break down. So the partial thickness will be there. So it's a shallow open ulcer, or the blister formation will be there. So if there is a blister formation there, definitely the skin will break down. The the dermis layer will break down. This is the second stage. The third stage is the full thickness ulcer. All tissues will be affecting. The subcutaneous tissues will lose. You can see the picture. The subcutaneous tissues will be affecting. Sometimes tunneling will be there. The tunneling is a narrow opening or a passageway that can extend in any direction through the soft tissues. You can see that picture. So this is called tunneling. If the patient is having tunneling, the wound has tunneling, you have to give, when we do the assessment, you have to do better assessment. If the wound has any tunneling there, you have to give special attention on that area. Otherwise, the wound won't heal properly. So coming to the fourth stage, exposed muscle, bone and tendon will be there. You can able to visible the muscle, bone and tendon. So this is the fourth stage. And the fifth one is unstageable. So unstageable is, you can say this picture. You can't assess. You can say this is third stage or fourth stage. You can't assume and say, this is third stage. This could be fourth stage. So this is an unstageable wound. So unstageable wound is a black necrotic tissue or a SR. If there is a black necrotic tissue on the top of the wound, so we can't assess, we can't say this is the third stage or fourth stage. So we have to remove the slough from the top of the wound. Then only we can able to find out whether the wound goes to the third stage or fourth stage. So have to, what level is extended, that way we can decide the third stage or fourth stage. So when we document it, if you have seen these kind of wounds, you have to document it is an unstageable wound. So, and the another wound, the other one stage is deep tissue pressure injury. So the deep tissue pressure injury is, as I mentioned earlier, shear force. So it's a non-blanchable deep dark, the red, purple, maroon discoloration. These kind of the wounds will be there because of the shear force. So these tissues damage from inside to outside. Okay, so usually the pressure ulcer will be developed from the dermis layer to inside. Okay, but if there is a deep tissue injury there, the injury will be happening into the deep tissue like subcutaneous tissues, and from we don't know if there is any damage happened or not. If you apply more pressure, if you give more pressure on that area, definitely the skin will break down and finally come out of third stage or fourth stage. Coming to the assessment, we need to assess properly, doctors or nurse. If you have visit this kind of bedbound patients, either a bedbound patient or a wheelchair patients, we have to assess properly. So what are the things we need to assess? Assess the pressure points. So we understand that now we learn. So what are the major pressure points? You have to assess the pressure points, and also if the patient is already having a pressure ulcer, you have to assess pain, whether the patient is having pain or not. We learned already. So pain is what the patient says first. We don't assume and say, oh, it could be no pain, so you have to tolerate some kind of pain. These kind of words we don't tell them. You have to ask them. So this is a subjective experience. You have to ask the patient about pain. If they have pain, you have to give some analgesics before wound management, and then you can do the wound management. And also you have to assess the location, like measure width and length and depth if possible, because approximate width, length and depth you have to assess it and document it properly, because after your treatment, maybe after 1 or 2 weeks, you have to reassess the patients, and then if you document it properly, definitely we can able to see there will be any change or not, or if the treatment is not good, you can able to change the treatment plan also. And stage, now we learned about the stage. Presence of exudate. So exudate is the purulent discharge coming from the wound. That is called the exudate. And also assess for tunneling. So these all things you have to document it properly. Coming to the management part, as I mentioned earlier, always medicate the patient for pain before wound care. So this is very, very important. You have to ask them about their pain. If they have pain, you have to give proper analgesics, and according to the WHO ladder, then you can, after maybe if you give a systemic analgesics, you have to wait another 45 minutes and then you can do the, then manage the wound management. If you do the topical anesthetic agents, then you can wait for another 2 to 10 minutes and then you can do the pain management. So stage 1, if you have seen a stage 1 pressure ulcer, you have to do you can teach the caregivers to turn the patients, because if they have a stage 1 pressure ulcer on the sacral area, what we tell the caregiver is they need to give a position like a right lateral or left lateral position, not a supine position. If you provide a supine position, what happens? Again, continuous pressure, the skin will damage. So here is the you have to tell the patient about the turning techniques and excellent incontinence control also. Moist control is also necessary. And coming to the stage 2, so only the clean wound, there is no slug, only the dermis layer is breakdown. So no need of antibiotics. You can clean with normal saline. That is enough for the second stage of pressure ulcer. In third stage, fourth stage, and unstageable pressure ulcer, if there is a slug there, you can remove it surgically. Like you can do the slug cutting procedure, surgical debridement. You can do it, and then use normal saline for wound cleaning. So you can teach the patients about how to make a homemade saline. So I'll tell you later about how to make a homemade saline. And if there is an odor or infection there, if there is a as I mentioned earlier, third, fourth stage and unstageable wound there, definitely the bird smell will be there. So that part you can use metronidazole powder. So metronidazole powder is one of the good agent for controlling anaerobic bacterial infections. So that will help a lot. So you can put metronidazole. So you can mix with you can take a metronidazole tablet and crush it and make it a powdered form and mixed with a white petroleum jelly or a Vaseline, and then make it the jelly form, and then you can apply on the wound. So that then the wound will get to benefit. The metronidazole will give a antibiotic effect, like reduce the infection. And the white petroleum jelly will give a moisturizing effect to the wound. And the another thing is debridase ointment. So papain urea ointment. So this will help if there is a slough there. This will help to reduce the slough. But the thing is this is quite expensive. If the patient is not affordable, it's very difficult to manage. And also mega heal. If the slough is removed, then you can apply mega heal ointment also. And another thing is charcoal. So this is so one of the good agent for absorbing bad smell. The charcoal pieces. If you have a charcoal pieces, you can take 1 or 2 pieces and keep under the bed of the patients or in the corner of the room. That will help to absorb the bad smell. And also charcoal dressing is also available. This is expensive, but if the patient is affordable, you can suggest charcoal dressings also. And in palliative care, we don't use hypochlorite solutions like powder iodine solution and hydrogen peroxide solution for wound management. This will irritate the skin, and also at the same time, it will destroy the granulation tissues. That's we used to use normal saline for cleaning the wound. And finally, surgery consultation if the patient is having fourth stage ulcer. And also, you have to think about the prognosis of the patient. If the prognosis is good, if the patient's health condition is good, you can think about the surgery consultation. You can think about the flap surgery, and you can refer the patient to the surgeon, and you can think about whether see whether the skin grafting procedure is possible or not. And also negative pressure wound therapy. So this is also another management of that fourth stage pressure ulcer. If you use the negative pressure wound therapy, this will help to absorb and bad the exudate from the wound, and also at the same time we give a continuous that stimulation to the wound, and this will help to the wound heal faster. So this is the another way to manage pressure ulcer. So this will you can do with the help of the suction apparatus. So as I said earlier, homemade saline. So we used to give dressing materials and that normal saline to the patients, and we suggest dressing materials and homemade saline. You can buy it and use it. And sometimes, most of the time, the patient is not affordable and they will not buy it properly. And most of the palliative care settings will providing dressing materials, but you have to educate the patient about some home remedies also. Always they can use homemade saline for cleaning the wound, and also they can make some dressing materials in their home also. So how to make a homemade saline? They can take 500 ml of water and add 1 teaspoon of salt, boil it, cool it. So that after cool, they can use the same water for same normal saline, homemade saline for cleaning the wound. So these kind of wounds are not sterile. This saline is clean. So they can use this homemade saline for cleaning the wound. And also gauze, dressing materials. If the dressing materials are finished, so they can take a cotton, the saris or dhotis, and cut into the squares and then steam them in a deli cooker or something. So this will help to, if the dressing material is finished. So this is the another home remedies. You have to keep it in mind, and you have to tell the caregivers about this also. So we all know that prevention is better than cure. Here also, if you have seen a bed-bound patient, so always you have to think about the prevention of bed sore, how we can prevent it. So you have to educate the caregivers. Without caregiver support, especially when they go home, within the hospital, we are there, or nurses will take care of them well. But when they go home, the caregivers will take care of that patient also. Without caregiver support, we can't do anything. So we have to empower and educate the patient, and at the same time, we have to support the caregivers too. So what are the things we have to look into for prevention of pressure ulcer? Position change. Every 2 to 3 hours, they have to change the position for a bed-bound patient. You have to tell the pathophysiology of pressure ulcer formation to the patient, caregivers and as well as the patients. Then only they have to change the position. And also, even if the patient is in wheelchair, also they have to change. They have to release their pressure every 15 to 20 minutes. And manage incontinence. The another major cause of pressure ulcer is moisture. So here, if there is a incontinence there, you have to think about the catheterization. If the patient is willing to put a catheter, you can put a catheter. So otherwise, if they are not willing, we can't do anything. So then you can tell the alternate options like diaper. If they are not affordable, they can use their own clothes. But the thing is, if the linen is wet, they have to change the linen as soon as possible. And also, you can suggest some special mattress like air mattress and water mattress, or pillows and cushions. So these are the things will help them, because if you suggest air mattress or water mattress to the patient, you have to tell them. So this is not 100% prevention of pressure ulcer. This will help you. Someday this will help, because this we don't have any literature like this for 100% prevention. If you put the patient in the whole day and that airbed without position changing, definitely the patient will develop pressure ulcer. So this will help. But so if you suggest air mattress or water mattress to the patients, they might be thinking like, oh, this will take care of everything. We can put this under the patient. So after that, they will not change the patient position. So that is where that patients will develop pressure ulcer. So we have to educate the patients properly. And nutrition, hydration, exercise. So this is also very, very important. If if they are not taking well balanced diet, like protein, lack of protein intake in their diet can cause pressure ulcer. And also exercise. So whenever we turn the patients from one position to another position, you have to give some massage. And our weight, that intention is to improve the blood circulation. Okay, if the patient is having good blood circulation under on the skin, so the patient will not get pressure ulcer. If they have a continuous pressure, whenever they turn the patient from one position to another position, they have to special attention to the pressure points. And also they can take liquid paraffin or white petroleum jelly or coconut oil, and they can give some massage, the simple massage on the dependent areas, that will help to improve the blood circulation. That way we can able to prevent pressure ulcer formation. And also wrinkle-free bed. Always you have to give wrinkle-free bed. If the wrinkles are present, the bed, the linen has wrinkles presence, again the patients can develop pressure ulcer. Nail. So here, if there is if the patient is having a nail, the patients will scratch their own skin, and then that if you give more pressure on that area, the patients will develop pressure ulcer on that area. So this is the small tip for you. Also, double SKIN. Whenever you have seen a patient, a bedbound patient, you have to keep it in mind. Double SKIN. So the first S is supporting surface. So make sure your patient is getting relief or proper supporting surface, like air mattress or water mattress or air cushions or pillows, cushions, whatever it is. You have to think about that. The first S is supporting surface. The second is skin inspection. So whenever you have to turn the patients from one position to another position, you have to give a special attention on the bony prominence, especially on the bony prominence, but all the areas you have to assess it. If they have any color change, if they identified any color change on that area, they can able to give special attention on that area also. And the next the point is K, keep moving. So always the 2 to 3 hourly have to change the position. The next one is incontinence. I is incontinence or moisture control. So bladder and bowel care is very, very important. If they have incontinence, you can think about catheterization, and also you can think about diaper or linen. You have to educate the patient well. And finally, nutrition and hydration is also important. You have to make sure that they can take right diet or fluid intake. You have to look into. So always you have to keep it in mind, double SKIN. So coming to the end case. So as I mentioned earlier, without caregiver support, we can't do anything. With the support of caregivers, we can do some support to the patients, and we can prevent pressure ulcer formation. How to engage the patient and family with the care. So we have to train well. So always we use the term you. You should do like that. You should do like this. We always use the term you. Instead of you can use the term we. If we use the term we, so they also think like, okay, somebody's begging them to support. them. So they feel more support. So that way we can develop a contact with them, and you can, if we start the word you be, so always if they develop a contact, and also you can develop the good relationship with them, and they, if they have any doubt in their mind, definitely they will call you so directly, because you are willing to support your word. From your word itself they understand, okay, so they are willing to help us, so they are ready to help us, and they will be there to help us. So even whenever you have seen this kind of patients, if you ask the caregivers about your problem and all, they will cry, because nobody's have much attention to the caregivers. We are the person to listen to the caregivers part also. Now we learned about palliative care. Palliative care is not only for the patient, for the family also. So we have to give a special attention to the family members also, because they need to work, give a care to the patient, and also they have to give the whole family works, and also they have cook. They need to cook the food for the family members. That all things they have to look into. At the same time, they have to take care of the patient also. Always you have to keep it in mind when we take care of, when we see these kind of patients. And also you have to give some leaflets like this. So this is a Malayalam leaflets. Whenever you have seen this kind of patients, if possible, you can make it in your own language and keep it in the room. And if they have any doubt, they can go and look into, and they will turn the patients. And from this picture, they can able to understand what how it turn, and what are the which areas they will give that pillows and all from this picture. So if possible, you can give this kind of leaflets to the patients, caregivers, that room. They can keep it in the room, and whenever they go inside for care the patients, they can give, they can take. So this is cancer wound. This is a non-healing ulcer. So the major difference between the pressure ulcer and the cancer wound is pressure wound is preventable and most of the time curable. This is not preventable and curable. This is a non-healing ulcer. So this is a primary or secondary malignant growth in the skin, which has ulcerated and difficult to heal. So the term fungating refers to a malignant process involving both ulceration and proliferative growth. So it could be like say nodular fungus or a cauliflower in shape. Okay, so here, so not because of fungus, it looks like a fungus shape. That is why we call it as fungating wound. So the both that ulceration and proliferation will be the same times. Because of that, lot of necrotic tissues and malodor will be coming out, and exudate will be there. This kind of wounds. And coming to the pathophysiology, we all know that what is what is the pathophysiology of cancer wound. So usually develop a non-tender skin nodules. So what happened if there is a skin nodules there? Definitely that will enlarge, and if the nodules enlarge, that leads to disruption of capillaries and lymph vessels will be there. That leads to altered coagulation, finally tissue hypoxia and necrosis. This is the pathophysiology of the cancer wound or fungating wound. So I don't know how many of you heard about or how many of you have seen about on the Marjolin ulcer. So Marjolin ulcer is a type of malignancy of the skin. So it is a malignant change in a chronic wound. So example, burn scar ulcer, pressure ulcer, venous leg ulcer. This is this kind of chronic type ulcers can develop from this wound, develop as this cancer, like the skin cancer. Most of the time, this common cell carcinoma will be there. And pathophysiology, this little bit different. pathophysiology is there. Here, appearance of mass in the wound, usually not present. We might be thinking like a granulation tissues on the wound, but at the same time, the patients will experience pain on that area and not previously present, and also change in character, volume, and appearance of drainage that from the wound. If these kind of changes will there, better you can refer the patient to the surgeon or oncologist and find out whether the patient is having marginal ulcer or not. If they have a marginal ulcer, it is a curative, the chance of cancer. So better you can refer the patients for the curative management. Coming to the problems. So as I mentioned earlier, this is a non-healing ulcer. There is a lot of problems will be there because physical problem will be there, psychological problem will be there, social problem will be there, spiritual problem will be there. So what are the physical problem? So let's see one by one. Pain. So here the direct exposure of dermis can cause pain, and also the tissues, the malignant growth will be compressing the blood vessels or nerves. That time the patients will experience neuropathic pain. So if the patient is complaining of pain, you can ask them whether the patient is having neuropathic pain or nociceptive pain. You have to assess it properly, and also the dressings are adherence to the wound. If you are not soaked properly before removing the old dressings, that is also can cause pain. So these are the way the patients can develop pain. And malodor. So here there are a lot of necrotic tissue in the wound because of that anaerobic bacterial infection, because of the devitalized necrotic tissues can cause malodor. And also stale X-ray dressings have been number of days, placed in number of days. That can also develop malodor. And bleeding. Again, so sometimes this kind of wounds will be protrude the major blood vessels. So that time there may be some patients, especially head and neck cancer patients, that will be dying because of bleeding, profuse bleeding. So we have to, if these kind of the cancer there, we have to prepare the family members also, and also exudate. So here, and so a lot of exudates will be there because in the wound, if they have the cancer wound there, because the hyperpermeability within on the blood vessels within the tumor. So that can cause again the dilatation will be there again. Lot of exudates will be coming out. Itching will be there. Infestation with maggots. Sometimes maggots formation will be there. Communication difficulties, especially head and neck cancers. If they have a CA buccal mucosa, they are not able to speak fluently because of the tumor. So what you can do is, when we do the assessment, you can give a chit of paper and ask them if they are able to write down their problem. You can give a chit of paper and ask them to write down their problem. From the paper itself, we can understand their problems well, and we can able to treat the patient well. So these are the major physical problems that kind of patients will be that suffering. And coming to the psychological part, altered body image. So this is one of the major problem, because you can just imagine a big pimple in your face. So if you get a chance to see the mirror, so how many times you go there and see, so whether the size is increased or decreased, these kind of things will be there. Here is a non-healing ulcer. Day by day, the wound size will be increasing. So this will be affecting the patient a lot. So sometimes they will be going to depression also because of this kind of non-healing ulcer. And disfigurement is also there, and sexuality will be affecting because of the misconception of the disease will be there, and denial will be there. The people may not accepting the truth sometimes. Even if they know well, they may not accepting these kind of things will be there. So if they have denial there, we know take it as a challenge and make them understand, no, this is not going to heal. So they will understand gradually. So if they tell like that, you can listen them and leave them alone, and they will understand gradually. And fear will be there. What happened next? Depression, and they will be anxious. But because the wound size, because of they will be doing a lot of treatment, but after that also their wound size will be increasing. So that will be the patients will be anxious about that. And finally, if the treatment is not benefited well, they will be there is a chance of the patient will go to depression also. Shame will be there, guilt will be there. These are the psychological problem the patients will be facing. So coming to the social problem, family isolation. So this is also is a major problem. So if one person can develop this kind of ulcer in a family, the family members can choose a corner side room and keep the patient there. They will not allow the patients get into the the kitchen and the dining area, and they will keep the patient there itself, because of maybe bad smell or accident, these kind of problems. So what we do is, if we identify this kind of problem there, better you can do a better symptomatic management. If you do the symptomatic management well, so they can able to include them also, because of the maybe these kind of physical problems, they may not willing to sitting near to them, or they are not willing to enter accepting to maybe because of their maybe unhygienic, or these kind of things will be there. So these kind of family isolation will be affecting the patients psychologically. And social isolation, society will be isolated these kind of patients. The maybe before that he or she has lot of friends and relatives. Because of this kind of ulcer, nobody is willing to come and see this kind of patients. Because of these things, these patients will affect emotionally. Social stigma will be there, fear of contagion because of the misconception. And effects on family will be affecting a lot. And also sexual relationship, it will be affecting the sexual relationship and marital disharmony also, because nobody is willing to marry a person this kind of family, because this kind of always we thought like this is a hereditary, this person can also get this kind of problem. So these all problems will be affecting the patients, not about the not for the other persons. Because of me only, my daughter is not getting a marriage because of my problem. This will be affecting the patient psychologically and spiritually also. Because if they have these kind of wounds, they will be thinking like, because of my sin, God punished me like this. These kind of things will be there. So always, why I am telling this all problem is, when we do the assessment, you have to give, if possible, you can do the individual assessment in front of the caregivers. They should not tell the truth. They will hide the truth, because in front of the caregivers, they will be saying like, okay, she will take care of me well. If you do the individual assessment, they will tell like, definitely nobody is willing to take care of me. So if better, you can do the individual assessment, so that we can get the good picture about the patient. And also you can assess, when we do the assessment, you can do the own location assessment, because mobility impaired, we can can be able to covered with from public view. So this is very, very important. We had a patient who had a buccal mucosa cancer. He used to bring a long towel when we come to the OP. So I used to ask them, why you are bringing this kind of towel with you always. So what he told me was, I need this towel, because when I get out of the hospital, or when the traveling by bus, nobody is willing to sit near to me because of my wound. If I cover it with a towel, so nobody's see my wound, and they can come and sit near to me. So this will like if they are afraid to sit or if they are reluctant to sit near to the person, they might be thinking like, because of my wound, so why God punished me like this? These kind of things will be there. So if possible, you can cover the wound properly from the public view. And wound appearance, surrounding skin, potential for complications. So here, as I mentioned earlier, especially head and neck cancers. So there is a chance of protrude the major blood vessels because of the tumor erodes. The tumor will erode the major blood vessels. So if the patient is in the home, so we need to educate them and support them, because they don't know how to manage. We have to give education to the caregivers. And coming to the management, the principles of management of fungating ulcers, try to relieve their symptoms, like palliation of symptoms. So if they have a pain, you can give some analgesics before that and try to manage their pain first, and then you can do the wound management. If they have a infection there, you can give some antibiotics or topical antibiotics or systemic antibiotics. That way we can able to reduce the infection. And managing exudate. So if they have a lot of exudate there, you can educate them how to manage the exudate and minimize bleeding. Here, as I mentioned earlier, the dressings are adherents to the wound. So before removing the all dressings, we need to soak the dressing well, and then you can remove it. Otherwise, bleeding and pain will be there. Okay. And holistic care. So holistic care is a total care. Now we understand that what are the physical problem, what are the social problem, what are the psychological problems, what are the spiritual problems that persons will be looking underwent. So these are the problems. So this person need a total care, physical care, emotional care, spiritual care, and social care. And always you have to empower the patient and family in wound care, because no, we are not able to go to the home every day and do the dressings. What we do is we used to train the caregivers and empower the caregivers for wound management. So criteria for wound dressing is, our goal of care is to maintain or improve the quality of life through symptom control. If you give a good symptom control, definitely we can able to improve the quality of life of the patient and their family. So always you can putting ourselves into their shoes, like empathetic care. The patient need an empathetic care. So always you have to think about their side also. Like we can, if you think like that, definitely we will do something for the patient. And provide a thorough bath before dressing. If possible, you can encourage the patient to take a thorough bath, because all necrotic tissues will fall on, because there are a lot of necrotic tissues there. These kind of wounds are fragile. So without applying pressure ulcer, if they are able to take a good bath, so they can take it, and that way we can able to wash out the necrotic tissue, devitalize to necrotic tissue from the wound. And always, as I said, like make sure that the patient is having the pain or not, and you have to keep it in mind always. And you have to use normal saline for cleaning of wound. Here also you can use normal saline for cleaning the wound. The selection of dressings depends upon the wound size and exudate amount. Coming to the pain management, if the patient is having deep pain, like systemic, like aching, stabbing, continuous pain, like nociceptive pain, there the systemic analgesics will helpful. Because, for example, if the patient is having 10 milligram morphine 4 hours early, when you go for a home visit, if they have pain, you can give a breakthrough dose. You can give an extra dose and wait for another 45 minutes, and then you can make sure that whether the patient is pain free or not. Then you can do the dressing. If they have a superficial pain there, like a neuropathic pain there, your systemic analgesics may not work well. So then you can think about the local anesthetic agent like sensorcaine or lignocaine. And you can apply on the wound and wait for another 10 minutes. Then that patients will get a local anesthetic effect. Then after that, you can do the wound management. Coming to the malodor management, daily cleaning and dressings. Here, you can clean with normal saline, and also you can apply metronidazole powder. This is the drug of choice of controlling anaerobic bacterial infection is metronidazole. So this metronidazole, you can take it and crush it, make it a powdered form and apply on the wound. And also you can use injection metronidazole. So these kind of wounds are having lot of pocket formation. Your system, maybe topical metronidazole not goes inside well. So that time you can use injection metronidazole for wash out the wound. So the injection metronidazole will go to the entire area and will help to reduce the infection. And also you can think about the systemic antibiotics also. But in the superficial areas, the blood supply is not good. Maybe it may not work well, but you can think about the course of antibiotics also. Frequent changing of dressings depends upon the wound size and the exudate level. Here also no hydrogen peroxide and betadine. So coming to the bleeding management, always you can try think about the prevention before removing the old dressings. You have to soak well and try to remove it. If there is a bleeding there, apply local pressure, as we all do that. Local pressure is if you apply local pressure, usually the bleeding will stop. If the bleeding is not stopped, you can think about the sucralfate powder as we used for peptic ulcer management. The same tablet, crush it and make it a powdered form and apply on the bleeding area. That will help to stop bleeding. And also tranexamic acid, you can think about that also. Then you can go for a systemic ethamsalate, and then you can think about palliative radiotherapy. And always you can educate the patient about the dark color cloth. So if there is an accidental that hemorrhage, bleeding, profuse, maybe the emergency, like the tumor will be protruding the major blood vessels. So that time the bleeding will be severe. So the better way to wipe out the blood with the dark color cloth, so that we can reduce the panic, like anxious level. Because if they use white color cloth, the patient and the other family members will be anxious, and they will be panic also. So they can use dark color cloth for wiping out the blood. Role of cancer therapy is radiotherapy, cytotoxic chemotherapy, hormone therapy, and surgery. So this will help to strengthen the size of this tumor. The radiotherapy and chemotherapy, hormone therapy, this will help to strengthen the size of tumor. If they these kind of maybe the tumor size will erode the blood vessel. If you have things like that, you can think about this. If the patient is if the patient health status is okay, then you can refer the patient to the oncologist and see whether the cancer therapy, is there any role of cancer therapy in that time. And also you can think about the surgery. Debulking surgery is also there. So if the patient is the health status is okay, then you can think about that also. Finally, maggots. So I think most of you know about the maggots formation. How does maggots come? These all things you all know that the maggots come from flies. The house flies is attracted with the infected wounds. If they touch the wound, they may lay eggs. Definitely within 8 to 12 hours, they come out of maggots. So you have to give a education. You can try to prevent maggot formation is the first thing. We have to educate the patient and as well as the caregivers about the importance of covering of the wound. So if the wound is open, definitely the house flies will attract the wounds and may lay eggs, so that the patients will have maggots. So you have to educate the patient well. And if they have developed maggots, you can think about turpentine. The turpentine is the best oil to remove maggots. What you can do is you can take a turpentine with the gauze piece and soak well, and you can keep close to the wound, so that then the maggots will come out. So that then you can take it out with the help of artery forces. Physical removal is the only way to remove the maggots. And another important message I want to convey with you all is don't follow maggots, because when you go with your artery forces, the maggots will go inside and keeps safe inside, because there are a lot of pocket formation will be there. If you go with your artery forces, what happens? Your artery forces will damage the major blood vessels. Okay, so that's why don't follow maggots. When they come out, you can take it out. Okay, so this way we can able to manage maggots. So thank you.